To my senior, juniors, and dear colleagues, my topic of today's presentation is portopulmonary hypertension management and diagnosis update. Although it is regarding updates, but I feel that rather than updates, we need more of a revision. At least I need it. So about the introduction, portopulmonary hypertension was first described by Mans and Mans and Craig in 1951. As the name implies, it involves both portal and pulmonary circulations. POPH is the concomitant presence of pulmonary arterial hypertension and portal hypertension in patients with or without cirrhosis. It is well recognized form of pulmonary arterial hypertension that results from complex pathophysiological interactions between the portal and pulmonary circulations. Rarely, some patients with POPH can have portosystemic shunts in the absence of portal hypertension, that is congenital extrahepatic cavoportal shunts. Pulmonary arterial hypertension can develop in up to 2 to 6% of patients with portal hypertension. In PH registries, patients with POPH constitutes about 5 to 15% of fraction of patients with PH. Female sex and autoimmune hepatitis have been recognized as independent risk factors for POPH, and it is detected in up to 30% of children with portal hypertension in pediatric studies. So where does our portal hypertension comes in the classification? There are five groups of pulmonary hypertension. So our portal hypertension comes in the group 1 in the 1.4.3, that is associated pH category. So going on to the further classification, the purpose of classification of pulmonary hypertension remains to categorize clinical condition based on similar pathophysiological mechanism, clinical presentation, hemodynamic characteristics, and therapeutic management strategies. So again, we can see the five groups. Group 1 is pulmonary arterial hypertension. Group 2 is the pulmonary hypertension associated with heart diseases. The group 3 is related to lung diseases. Group 4 is related to pulmonary artery obstruction, and group 5 is miscellaneous. So as we can see, our pulmonary arterial hypertension is a rare group, and POPH constitutes 5 to 15% of that group. So what are the pathophysiological mechanisms behind portopulmonary hypertension? So as we know, in this cirrhosis, there is an increased resistance and increased portal pressure gradient that leads to portal hypertension, and further leading to a hyperdynamic state in which there is an increased endothelin 1 and interleukin 6, which reach to portal and pulmonary circulations, leading to a net vasoconstriction and increase in pulmonary vascular resistance. So as we can see, in the presence of chronic liver disease or the shunts, there is a hepatic dysfunction, splenic vasodilatation, hyperdynamic circulatory state, and portosystemic shunts. There is a bacterial translocation, decreased hepatic blood flow, shear stress from increased systemic blood flow. There is a secretion of endothelin and other vasoactive agents that leads to net vasoconstriction and vascular remodeling. Again, in the same, at the pathological level, there is an intimal proliferation, there is a medial hyperplasia in the pulmonary arteries. They are plexiform lesions, and which leads to right ventricular remodeling and dysfunction. So these pathological changes we can also correlate with the therapeutic aspect. So there are 3 pathways: endothelin pathway, nitric oxide soluble guanylyl cyclase, and CGMP pathway, and prostacyclin pathway, which will have relevance in the treatment strategies. What are the new hemodynamic definitions of pH? So for classifying pulmonary hypertension, there is a must criteria of mean pulmonary arterial pressure of more than 20 mmHg. This is typical for all groups. Coming on to the next, precapillary pulmonary hypertension, which relates to our group of pulmonary arterial hypertension, a mean PAP requirement of more than 20 mmHg pulmonary vascular resistance of more than 2 Wood units, and pulmonary arterial wedge pressure of less than 15 mmHg is required. Combined pre-capillary and post-capillary hypertension, mean PAP is more than 20, PVR is more than 2, and pulmonary arterial wedge pressure is more than 15. In isolated post-capillary portal hypertension, this group is solely related to left heart diseases. The pulmonary vascular resistance is less than 2 Wood units. There is a separate category of exercise-induced pulmonary hypertension in which more than 3 millimeter per mercury of per unit liter outputs per minute of cardiac output, and exertional dyspnea with preserved LV function that defines the exercise pH. The new hemodynamic definitions of pH emphasizes that mean pulmonary artery pressure more than 20 and PVR more than 2 Wood units as a strategy by which to capture patients earlier in the disease arc. So this pictorial representation, which led to the changes of pulmonary arterial mean pulmonary artery pressure threshold from 25 to 20 and pulmonary vascular resistance from 3 Woods to 2 Woods units, a large cohort of patients is followed and modeled for. So in this pictorial representation, we can see the inflection point of mean pulmonary arterial pressure of 20, beyond which the hazard ratio has started rising rapidly, and similarly for pulmonary vascular resistance more than 2 Woods units, there is an inflection point for mortality hazard risk. What are the diagnostic criteria for POPH? So this is where right heart catheterization, we are dealing with the right heart catheterization criteria for diagnosis. So mean pulmonary arterial pressure, originally it was more than 25, now reduced to more than 20. Pulmonary artery wedge pressure should be less than is equal to 15, and pulmonary vascular resistance more than 2 Woods, and in the absence of any other reasons for pulmonary arterial hypertension. Diagnosis: unexplained precapillary portal hypertension in patients with portal hypertension or a portosystemic shunt. The diagnostic approach is same as in other patients with suspected or newly detected portal hypertension. Transthoracic echocardiography is usually the first non-invasive assessment. Patients with liver disease often have elevated cardiac output, and the tricuspid regurgitant velocity tends to overestimate the PEP. Hence, right heart catheterization with comprehensive hemodynamic assessment is essential to confirm the diagnosis of PH. What are the features suggesting of portopulmonary hypertension in the patient with cirrhosis? So these are the same kind of, in the history we can see the dyspnea, fatigue, chest pain, syncope, weight gain, lower extremity edema. There could be ascites, indistinguishable from the background liver disease, and the clinical evidence of portal hypertension could be there. In the physical sign, there could be jugular venous distension, wide split second heart, loud P2, tricuspid regurgitation, murmur, parasternal heave, hepatomegaly, pedal edema, and ascites. Signs of cirrhosis could be there. Features suggesting portopulmonary hypertension in patient with cirrhosis. So on the imaging and electrocardiography, on the CT scan, main pulmonary artery to ascending aorta diameter is more than is equal to 1. Normally aorta is larger than the pulmonary artery. Dilatation of right atrium and ventricle. In the electrocardiography, there could be signs of right ventricular strain, right axis deviation, right atrial abnormality, P pulmonale, and HVPG of more than 6 mmHg. In echocardiography, there could be enlarged right atrial area, reduced right ventricular ejection fraction, flattened interventricular septum, right ventricular to left ventricular basal diameter of more than 1, peak tricuspid regurgitant jet velocity more than 2.8, right ventricular systolic pressures of more than 45 mmHg, decreased apsy pulmonic insufficiency, pulmonary artery diameters of more than 25 mm, inferior vena cava diameter more than 21. So this is the CT scans of few patients which I could search from the data collection. So in the first case, we can see this. This patient has pulmonary artery around 41 millimeter, and relatively aorta diameter it is barely visible, but 31 millimeter of aorta. So even visibly the pulmonary artery is large. The predicted systolic systolic arterial pressure was 52 plus right atrial pressure. So it classified to moderate pH. Serum NT-proBNP was around 1000. In the second case, again the pulmonary artery was 36 and the aorta was 33 millimeter, was classified as a moderate pH based on echo. In the third case, again the pulmonary artery diameter is 35 and aorta is 30, and serum NT-proBNP is to the tunes of 24,000. In the next case, it is from a female. Again, the pulmonary artery is bigger than the aorta. So pulmonary artery diameter is measured at the level of bifurcation of pulmonary artery, and the widest diameter is measured. So risk stratification, the POPH patients can be stratified in low risk, intermediate risk, intermediate high risk, and high risk based on these parameters: WHO functional class, 6-minute walk distance, BNP or NT-proBNP into 1, 2, 3 and 4 classes. What are the reasons for a limited knowledge of pH? So it is relatively understudied compared with the other subtypes of group 1 pH. So POPH was conventionally being excluded from drug trials because of concern about hepatotoxicity. Secondly, the low incidence of POPH means that patients with this disease are often studied in combination with other groups, other classes in the idiopathic pH to ensure sufficient sample sizes, and POPH has lower prevalence than other complications such as hepatic encephalopathy, ascites in the patient with portal hypertension. So diagnosis of POPH might be less of priority for hepatologists. Therapy. In the patient with established diagnosis of POPH, treatment should follow the same general principle as in other patients with pulmonary arterial hypertension, taking into account the severity of underlying liver disease, the indication of liver transplant, the potential effects of pH medications on gas exchange, and which may deteriorate with vasodilators in patients with POPH. So coming to the medical management, all drugs approved for PH can principally be used to treat patients with POPH. So various case series and RCTs support the use of approved PH medications in patients with POPH. In patients presenting with mild liver disease, main cause of death are pH progression and malignancy, whereas complications of liver disease is the most common cause of death in patients with advanced liver disease. Patients with unclassified pH, where mean pulmonary artery more than 20 mmHg classifies as a portal hypertension, but pulmonary vascular resistance is less than 2 Wood's units, should regularly be followed but should not be treated with drugs approved for pH. So this is from large review from portopulmonary hypertension, the current era of pulmonary hypertension. So in this large cohort, the initial pH therapy was started in 90.1% of patients. One group with endothelin receptor antagonist, then second with phosphodiesterase 5 inhibitors, and other with oral combination therapy. So we can see there is a reduction in -40%, 37% and 64% in pulmonary vascular resistance in this study. The survival pH cohort, there is at the 5 months you can see that there is a 50% survival. Cirrhotic patient versus extrahepatic portal hypertension, there is a decreased survival. Survival according to child pug classes, so definitely the C class patients have 20% survival at 5 years. The child B has around 50% survival at 5 years, and child A at 60%. So short-term effects of initial treatment strategy on cardiopulmonary hemodynamics and 6-minute walk distance. So again, from the same study, the endothelin receptor antagonists reduce the mean pulmonary arterial pressure by 7 mmHg, the phosphodiesterase inhibitor again by 7 mmHg, and combination therapy leads to a decrease of 15 mmHg in the mean pulmonary arterial pressure. Similarly, cardiac output rised with the in all these classes, more so with combination therapy. Pulmonary vascular resistance decreased with all therapies, and 6-minute walk distance also, but that was not significant. Survival of transplanted and non-transplanted patients according to child pug stage and MELD score. So definitely with transplanted patient in portopulmonary hypertension, there was a survival of 80%. Without transplant, the 5-year survival was around 60%. So in child pug B and C, there was again good survival, but without survival, the without transplant survival was around 20%. According to MELD also, the survival was different with or without transplant. What are the drugs used for portopulmonary hypertension? So these are similar kind of drugs which are approved for class 1 pulmonary arterial hypertension. There is a group of prostaglandin analog, that is prostanoids, which include epoprostenol, iloprost, treprostinil, endothelin receptor antagonist, bosentan, ambrisentan, macitentan, phosphodiesterase inhibitor, sildenafil, tadalafil, and riociguat, that is guanylate cyclase agonist. So with these therapies, which we will come to later again about the dosing, there was a functional improvement with the prostanoids, increased exercise capacity, mean pulmonary artery and PVR improvement. With endothelin receptor antagonist, there was an increased exercise tolerance, mean pulmonary artery PVR improvement. With phosphodiesterase inhibitor, also 6-minute walk test, mean pulmonary arterial pressure and PVR reduction. But with this riociguat, there was only increased exercise capacity in the form of 6-minute walk test, but not in the mean pulmonary arterial resistance. Or so there were the side effects related to prostanoids were headache, influenza-like symptoms, cough, tongue pain, syncope, pain, cutaneous reactions. With endothelin receptor antagonist, there was a concern of hepatotoxicity, more so with bosentan and lesser with further next generation endothelin receptor antagonists like ambrisentan and macitentan. Sildenafil again led to headache, myalgias, priapism, diarrhea, variceal hemorrhages. Riociguat leads to headache, dyspnea, nausea, vomiting. All kind of symptoms are similar with these group of medication. So coming about the few of the documented trials in this portopulmonary hypertension population. So coming to this Portico trial, this trial showed a 35% reduction in pulmonary vascular resistance in macitentan group compared with the placebo. So patients included were with child A and B, and child C was excluded, and higher MELD groups were excluded. No hepatic safety concerns were seen in this study. Again, from the next trial, which was for all PH classes, patent 1 and patent 2, a subgroup of which has shown that riociguat has led to improvement in 6-minute walk distance. Third trial, which was an open label trial of ambrisentan 10 mg once a day. It was also in child pug class A and B. Again, this trial has shown that there was an improvement in pulmonary vascular resistance and other secondary outcomes. So riociguat treatment for portopulmonary hypertension, this was a subgroup analysis from patent 1 and patent studies. This study has shown that there was an improvement in 6-minute walk test, and there were not much of side effects. A part of the trial from ambrisentan study, in the portopulmonary hypertension, we can see that there was a reduction in pulmonary vascular resistance after 24 weeks of therapy. There was a reduction in mean pulmonary arterial pressure. There was improvement in cardiac output and cardiac index after the ambrisentan once a day 10 mg trial. This table is again showing that there was a significant improvement in mean pulmonary arterial pressures. Pulmonary capillary wedge pressure remained the same. The pulmonary vascular resistance has decreased significantly. For the macitentan trial, the Portico trial, so pulmonary vascular resistance at week 12 expressed as a ratio of baseline in the full analysis set. So we can see that with macitentan as compared to placebo, there was a significant reduction, proportional reduction in pulmonary vascular resistance. For the same trial Portico, the 6-minute walk test, they showed not much of the significant difference. And again, for the macitentan, this effect of macitentan on primary endpoint by pre-specified subgroups individually, although it is not significant individually, but overall direction favors use of macitentan for the improvement in parameters. These trials again shown that the more significant side effects were related to peripheral edema, headache, anemia, bronchitis, dizziness, pain, hemoglobin decrease. Not much of the hepatic side effects were documented. This is again a trial which for the pulmonary arterial hypertension as a group, in which there was a 41% reduction in risk of disease progression with initial triple therapy versus initial double combination therapy. There was no treatment effect to the individual parameters, but overall survival was better with initial triple drug therapy. So these are the drugs which can be used. So for the relevant drugs for us, ambrisentan 5 mg per OD can be started and later on escalated to 10 mg OD. Macitentan can be started at 10 mg OD and later on can be continued with 10 mg OD. Tadalafil also can be given in OD doses of 20 to 40 mg OD. Prostacyclin analogs, they are costly and there is a limited availability in India, but we can use during inpatient. Rioshiguat, which is infrequently used in some of the POPH cases in our institute, also can be started with 0.5 mg TID to 2.5 mg TID. These are other novel therapeutics in pulmonary arterial hypertension which are under investigation. So we can see the imatinib, seralutinib, which are tyrosine kinase inhibitor, and bone morphogenic protein agonist, sotatercept, active in sequestration and rebalancing of SMAD. Other therapies which are used for other indications like tacrolimus, anastrozole, tamoxifen, they also can be given. Some intriguing studies about endothelial cell progenitor cells, they can also be, they are under trial. So about a word of in liver transplant. So POPH is not an indication for liver transplant. PH poses a major threat to the patient who undergo liver transplant when indicated for severity of liver disease. In a historical series from the Mayo Clinic, severe PH was associated with 100% mortality, and even lower moderate PH ranges were associated with 50% mortality. LT candidates with PH targeted medical therapy successfully improves hemodynamics and establish eligibility of transplantation. Hemodynamic criteria for successful LT have not been firmly established. So what is the priority statement in portopulmonary hypertension, mild exception? So baseline POPH diagnostic criteria should be met, and post treatment of POPH, the hemodynamics should be mean pulmonary artery pressure should be less than 5 units, and mean pulmonary artery pressure should be less than 35, or mean pulmonary artery pressure should be 35 to 45 mmHg, and PVR should be less than 30 Woods units. And for extension requirement, RHC has to be repeated every 3 months. The risk of LT is related to the development of right heart failure during and after reperfusion. Identifying which patient with POPH have highest transplant risk has been previously based on the level of the MAP more than 35 mmHg as determined via RHC. Most recent data, however, suggests that it is the degree of pulmonary vascular resistance which is more predictive of waitlist mortality, intraoperative and post-transplant outcomes rather than mean PEP. For the liver transplant perspective, what are the intraoperative medications? So continuing selected pH therapies like prostaglandin analogs to control POPH during transplant is necessary due to rapid decline in right heart function that can be experienced during reperfusion phase. Pre-transplant oral POPH medication should be reinstituted whenever feasible in the immediate post-transplant time frame, and to facilitate accurate hemodynamic monitoring during POPH-related transplantation, pulmonary artery catheters as well as transesophageal echocardiography should be readily available. about the extra need for extra corporeal membrane oxygenation, detection of unexpected severe POPH with subsequent planned ECMO used during LT has been successful approach in selected patient. There has been the use of planned preemptive veno-arterial ECMO in the setting of severe POPH as a bridge to transplant, and successful use of rescue veno-arterial ECMO intraoperatively due to acute right heart failure due to massive pulmonary embolism. About living donor liver transplant and multi-organ transplantation, only cases of LDLT in the setting of POPH has been reported. There are other case reports of possible dual lung liver transplant and lung liver and heart transplant, few case studies. So about the role of gut microbiota in the pH. So like other diseases, even in the pulmonary arterial hypertension, there are animal human studies which have identified changes in gut microbiota that are associated with pro-inflammatory changes at the sites and the pulmonary circulation. So this is a vicious cycle in which there is a endothelial inflammation and remodeling in leading to increased pulmonary vascular resistance, right ventricular dysfunction, venous congestion. There is a gut dysbiosis and increased gut permeability, which can be modulated by drugs, diet, infections, lifestyles, comorbidities, and there is a translocation of these vasoactive substances into pulmonary circulation. Again, the role of gut microbiota. So they talk of microbiota transplant in the portopulmonary hypertension setting with these engineered bacteria. So these mediators of vasoconstriction with the healthy microbiota which can inhibit this mediator. So they talk of this bacteria Akkermansia. Prognosis: 5-year survival without treatment ranges from 4 to 14%, but increases to 40 to 51% with specific treatment. 5-year survival patient with under liver transplantation was 81%. So this was also the Association of Cardiopulmonary Hemodynamics and Mortality in Veterans with Liver Cirrhosis patients. So we can see that POPH patients have the lowest survivals as compared to non-PH cirrhosis, hyperdynamic circulation, even post-capillary pulmonary hypertension that is related to left heart disease have better survival. This same plot is showing the hazard ratio associated with increasing mean pulmonary artery pressure. What are the unmet needs in the diagnosis and management of PH? So needs that have immediate clinical impact and should be considered on high priority. Needs that are very desirable but not of clinical urgency, and they are the needs which are desirable that can be filled as expertise, funds and type permit. Conclusion: portopulmonary hypertension, a form of pulmonary arterial hypertension, occurs because of portal hypertension. Pulmonary hemodynamics in the right heart functions are key entities that are considered when diagnosing and treating POPH. Medical management combined with LT offers a unique opportunity for POPH cure. However, transplant risk can be significant as it relates to severity of POPH. In addition to recent POPH practice guidelines, continued efforts can be suggested to improve our understanding of prognostic factors, investigate newer medical treatments and improve outcomes of POPH. Future perspective: there is a whole lot of areas there for further multi-center trials and registry studies are needed to ensure sufficient sample sizes. There are no randomized or control studies from India. Collaboration between physicians specializing in hepatology and PH may help to bridge the gap in their treatment strategies. So this is the proposed algorithm for management of PH from my side, that is subject to definitely input from other branches. So a suspected case of pulmonary hypertension should undergo transthoracic Doppler echocardiography. If systolic pulmonary arterial pressure is less than 30 mmHg, that has to be reassessed every 3 to 6 months. If it is systolic pulmonary arterial pressure is more than 50, which equates to around mean pulmonary arterial pressure of 30, then there can be two scenarios: if whether this patient is a candidate and willing for right heart catheterization, whether candidate not whether the patient is not a candidate and not willing for right heart catheterization, because right heart catheterization is associated with hazards. So if patient is not a candidate and not willing for right heart catheterization, I propose consider starting monotherapy or combination therapy with endothelin receptor antagonist, PD5 inhibitors or riosuate, a decision that has to be taken in conjunction with the patients. If patient is willing and is candidate for right heart catheterization and this criteria are established and other pH are excluded, then there we can classify patients into 3 groups. When mean pulmonary artery pressure is more than 20 and less than 30, no treatment is required and reassess every 3 to 6 months. The mortality is usual. If mean pulmonary artery pressure is more than 13, less than 40, consider starting monotherapy with these same agents. There is increased mortality and it has to be reassessed every 3 to 6 months, and mild exception is granted to this class. If mean pulmonary artery pressure is more than 45, we can start combination therapy with these agents. There is a high mortality. And goals, what are the goals of therapy? Mean pulmonary artery pressure should be less than 30 mmHg, it has to be reassessed, and pulmonary vascular resistance should be brought down less than 3 Wurtz units. And if this is there is a it happens, then if patient can proceed for LT as per indication. If no, it has to be reassessed. Similarly, other I could find very few cases. There are only 87 patients with 20 females and 77 males. I could not compile other data, but most of the patients were in moderate pH ranges, and only not very infrequently some of these patients were on riosuate. Thank you.